Okay, next up is Dr. Joe Bufil. Joe is an oncologist, and as I mentioned earlier, he's going to talk about the whole process of the cancer diagnosis. Joe?
Thank you. As Joe alluded, cancer is the second most common cause of death in the United States, behind cardiovascular disease, heart attacks, and strokes. And unlike heart attacks and strokes that are usually sort of catastrophic events that are unexpected, cancer is different in that once a cancer diagnosis is established, there's usually time to consider how this new illness is going to affect a person's life and a person's ability, their day-to-day activities. So it's, even though it's a catastrophe in a certain sense, in another sense, it's not, because it allows, again, time for reflection and for consideration of how to face the future with a new diagnosis. So what I wanted to do today is basically describe a little bit of the process of cancer care from the point of view of the doctor, and hopefully it'll help you understand from the patient's perspective what's happening over time in the course of taking care of cancer patients. Basically what cancer doctors do every day is they establish a diagnosis, or they receive a patient who has a diagnosis established already. They perform the tests that are necessary for what's called staging. They then take that information and determine a prognosis for the patient, and by prognosis, basically whether the illness is curable or not curable, and if not curable, then what the life expectancy might be. Finally, we determine the treatment, and after the treatment's completed, then we carry out sort of long-term surveillance and monitoring of a person's illness. And this is what we do every day in different, for each patient. And each patient obviously is in a different part of this process. So cancer, cancer is, as you know, not one illness. Today, cancer is classified based on the site of origin of the illness. So breast cancer begins in the breast, leukemias begin in the bone marrow, etc. And cancer is a unique category of illnesses in that what happens, the tissues in our body are constantly renewing themselves. Some tissues renew themselves very quickly, like the bone marrow or the bowel. The lining of the bowel has a very high turnover. Other tissues renew themselves very slowly, like the muscles and the brain. Those are tissues that rarely, turn over. But cancers can occur in any of these tissues, and it's thought that cancer is basically an abnormality of this process of self-renewal of the tissues. So what happens in cancer is that this process of self-renewal of the tissues gets messed up. And so the cells that should grow from immature cells to mature cells get stuck somewhere in that process. And that getting stuck means that they start growing in a disorderly way. They mess up the architecture of the original tissue, and then the cells acquire the ability to spread, they migrate to other parts of the body. That's called metastasis. And so that migration obviously is not a good thing. Cancers are much easier to cure if they are found early and they're removed from the site of origin as soon as possible. So a lot of times cancer will present in different ways. It could be a painless lump that the patient feels. It could be an abnormality of the labs that the doctor discovers. But once a cancer diagnosis is established, the next thing we do is more tests. And the tests basically are designed to try to understand where else the cancer has spread. The reason that's important is because the treatments are going to differ, and the likelihood of a cure is going to differ depending on how far the cancer spread. Some cancers are easy to cure and have an excellent prognosis, especially if they're limited to one place. Other cancers are curable even if they've spread beyond the tissue of origin. And I'm sure you're all familiar with a lot of reports of people being cured with advanced cancer. Lance Armstrong comes to mind as one example, but there are many other patients with certain types of cancers that can be cured even in their advanced stages. So once the staging treatments are completed, and staging implies a lot of times blood tests, genetic tests, X-ray tests, CAT scans, things like that. Once that process is completed, then we make recommendations about treatment. And the treatments can vary quite a bit. They vary from cancer to cancer. They vary within a specific type of cancer by stage. The treatments change depending on the stage of the patient. And in general, we have three weapons, so to speak, or three tools to try to help patients with cancer. One is surgery, the other is radiation therapy, and the third general category is chemotherapy or medicines. And each of these approaches, the emphasis on one or the other, again, varies according to the stage, how advanced the cancer is, and according to the specific type of cancer. And as I say, every cancer is different. We are, the experience in treating cancer is growing a lot and very quickly, and so the recommendations for specific cancers change very quickly as well. It's an area of medicine that is changing rapidly for the better. So we're getting better at curing cancers, we're getting better at minimizing the side effects of the treatments, and in general, there's been a lot of advances. I've been at this for upwards of 1989, that would be, 24 years. So just in the short time that I've been doing it, there's been a lot gained and a lot of advances that are making treatments much more effective. So once the treatment recommendations, once the prognosis is issued, basically the main distinction is this cancer curable? Is it not curable? What's the likelihood? If we think it's curable, what's the likelihood that it may come back in the future, et cetera? These are the types of questions that we deal with, and this is the type of information that we try to convey to patients and families, that what's the price of, what are the side effects? If we want to cure a cancer, what's the price that you have to pay, so to speak, not just in dollars and cents, but in side effects, in the quality of life, how tough are the treatments. And so we're constantly making these judgments that have to do with the risks of the treatments, what are the side effects, and the benefits. And that's kind of the calculation, so to speak, that we make. And I think in general, cancer doctors and most doctors value and kind of appreciate and weigh heavily the attitude and the opinion and the values of the patients, because obviously we're trying to serve your interests in treating these illnesses. So it's kind of a value, determination of value. What are the risks? What are the benefits? What are the patient's motivations and interests? And we try to together sort of come up with a treatment plan that then is executed over a period of time. And once the treatment is finished, then the treatment, depending on whether the cancer is curable or not, can have a curative intent, or it can have what we call a palliative intent. Palliation meaning relief of symptoms, meaning trying to either reverse or prevent the bad things that can happen throughout the course of the cancer illness. So once we've given a treatment and helped the patient kind of make it through the course of the treatments, then we begin what's called surveillance, or basically monitoring patients over many years, sometimes for the rest of their lives, trying to identify some of the late effects that can happen after treatment of cancer, trying to identify the possibility of a recurrence of the cancer sooner rather than later, so that we can address those problems if they come up down the road. And in a nutshell, this is kind of the things that we do for cancer patients. Don't know if there are any questions.
They haven't really come up with one single blood test, have they?
No, there's not one single blood test that's good to identify cancer risk. That said, one of the most important avenues of research involves genetic testing, for cancer predispositions. And one of the things that we've learned about cancer is that the whole process where a normal cell becomes a cancer cell, that whole process is driven by flaws in the genes that cause cells to grow and divide and what's called differentiate, mature, basically. So one of the big areas of interest in cancer research now is basically identifying what those flaws are and using them for different purposes, usually to identify targets for treatment or to identify people who might be prone to develop cancers over the course of their lifetime. So this whole thing of personalized medicine, that is kind of a blood test that in the future may, in some people, sort of identify what your risk is, not only of cancer, but of heart disease, and Alzheimer's, all sorts of different illnesses.
I have a question about organic versus non-organic eating. Are you in favor, or do you, I have a friend who's an oncologist, and she has no real belief in organic versus, I mean, she's not an organic nut.
Well,
You know what I mean? She's not like all about that all the time.
yeah, I don't think there's a lot. See, doctors, we tend to be real rigorous about the recommendations that we make. So before we say A is better than B, we want to see the data, and we want to see the research that supports that statement. And you guys can probably help me that, there's no clear scientific data today that says the stuff that you buy at the supermarket is any better than the green stuff or the organic stuff.
There's no data out there right now.
No data out there right now.
Okay.
But you don't follow your,
There's one way you can look at not a actual study is if you look at the percentage of cancers per 100,000 people in the United States over the last 100 years, and in that 100-year period, there's been very little change. The only major changes is lung cancer, which used to be very uncommon under 20 years ago, is now number one. Stomach cancer, which was number one, way down. And then recently, of course, a rise in skin cancer from everybody getting the tanning beds and all that kind of crud. But the actual rates haven't changed. Now, if you say organic versus non-organic, well, 100 years ago, everything was organic because they didn't have anything. But it's interesting to see when they invented food preservatives, it wasn't long after that that the rate of stomach cancer went down. Curiously, in Japan and China, where they don't use food preservatives, stomach cancer is still number one. So, although lung cancer is just about there, I believe now, for me to be smoking. Thank you, Reynolds Company.
Joe, is there some advice you could give to the healthcare consumer talking to their cancer doctor?
Well, I think the goal of meeting with your doctor, I think, should be to make sure that you, when you leave the office, you understand where in the, what the next step is, so to speak, where you are in the course of the illness, what you might expect from, the next step, and whatever that might be, whether it's the treatments or surveillance, and don't sort of assume that the question that I have in mind is sort of a dumb question or something. I think you have to, you should see the doctor as someone who's working for you. You're not there to work for the doctor, so to speak. And so you have to have your questions answered and your concerns addressed at every visit. So I would say that if you leave the office and there's some doubt or uncertainty, just say, wait a second, not so fast. Grab the guy by the lab coat, sit him down, and say, I have this. And in my case, I have the good fortune of having a nurse practitioner, and so sometimes the nurse practitioners are much more sensitive to these types of subjective concerns and questions of the patients, because sometimes doctors and the patients are at sort of a little bit of a different level. We're concerned more about the disease, and patients concerned about the impact on your life, and we may be a little insensitive to those types of things, whereas a nurse practitioner is more in tune with sort of the day-to-day impact of the disease on your life. So I think nurse practitioners can be very helpful in sort of clarifying things for patients, and they will usually, at least the way we have it in our practice, we allow the nurse practitioner more time than we allow the doctors with the face-to-face time. So, and the other practical thing is just come with a list of questions beforehand, and not just sort of wing it, so to speak. So